Thank you very much. I'm very grateful to you, Jonathan, and McGill University and the University of Montreal for the invitation. Thanks a lot. So, these are my disclosures. So basically, for years, I've been among the one that was receiving patients that most of the oncology considered palliative, because they were stage 3, but they were unresectable. They were bulky tumors with not only multiple nodes, but multiple bulky lymph nodes, N3, T4, and many, let's say, very difficult, very challenging cases. And the results with chemotherapy and radiation were better than radiation alone, but chemotherapy, cisplatin-based, was not enough to sterilize micrometastatic disease. At the end, we were losing most of the patients. With the best therapy we had, concurrent chemoradiation, we had 85% survival. Then we started seeing something that, without any new drug approval, it simply, the curve started going better, probably because of a better staging, for sure, introduction of brain MRI and PET-CT, and multidisciplinary discussion of the cases. That's been very useful. Our ability to push forward concurrent chemoradiation, and at the end, in the new generation of trial, pre-immunotherapy, pre-TKI, I have to say, we see this kind of cure, so 25% of patients cure. And now, and then with the Pacific era, we started a kind of, I would say, adjuvant immunotherapy, consolidation immunotherapy phase in patients who are able to complete chemoradiation without progressing. And as you can see here, you see an impressive, unprecedented seen results of overall survival. 47 months of median overall survival. In previous trial was around 25 at their best. And nice results also regarding PFS, which means patients who are free of disease, 33% at 5 years. And I'm happy also to present to you what we published a couple of weeks ago. It was a collaborative studies on real-world studies, including more than 1,000 patients that we follow up, included in the expanded access program of durvalumab in the year 2017-2018, and also in real life. As you can see, this is the first overall survival extraction, data extraction at 3 years. And as you can see, we have 63% of the patients alive at 3 years. And especially, we have a 2 years PFS of 50% of patients, which is very good for this kind of patients. And at the same time, we have many unmet needs. We have suboptimal distant disease control, because we are still losing many patients for distant progression. We have large tumors and the problem of local relapses, so we don't know exactly what to do with PD-L1 negative patients, because they do not respond very well to consolidation durvalumab. We have a kind of one-size-fits-all approach since 30 years, so chemoradiation, 60 grade to everybody, and it's evident that this is not the right way to proceed, in my opinion. We need to think about late toxicity, especially cardiac and lung toxicity, because we were losing a lot of patients, and we are curing approximately half of them, and so we then need to think about cardiac sparing strategies and lung sparing strategies. We also have the problem of what is the best therapy at progression. And in the field of clinical research, we are, many groups are doing different strategies, anticipating IO, different sequences, using IO combos or ctDNA-guided strategies and CRT modification. I will try to go over these strategies. One of the first strategies was to anticipate immunotherapy and giving immunotherapy concurrently with chemoradiation. And I have to say that the first data presented in small phase 2 study were not so encouraging, however, not too bad, but not so encouraging. This is one of Atezzo. This is the experience published by Solange Peters in the ETOP-NECLAS phase 2 trial. And here, again, this was a phase 2 study designed with a primary endpoint of progression-free survival, and the boundary of confidence interval was 45%. It's a little bit higher, but was negative formally in a statistical point of view. For sure, this was not the curve that the investigators were looking for. And we had also some problem in toxicity because many patients received 66 gray of radiation therapy and consolidation chemotherapy. These are for sure components of this study that can be discussed. At the same time, a study using consolidation nivolumab and ipilimumab or nivo alone following concurrent chemoradiation was published, giving, I would say, a median PFS that is 25 months and superior to Pacific. If you look at numerically at the numbers, not superiority for Nivo-Ipi, but unselected population, probably PD-L1 negative could be the right one to test this approach, and good overall survival. So promising results, again, not too much enthusiasm, but for sure promising results. But unfortunately, the press release of BMS regarding Checkmate 73L was negative, and so the phase 3 part that was designed to follow this early experience in phase 2 was not successful. And the same happened for the Pacific 2 story. The idea of anticipating durvalumab during chemoradiation with consolidation durvalumab versus, at that time, simply chemoradiation alone was not successful. And in a way, we were surprised also by the fact that, let's say, it's like as if giving durva during chemoradiation was abrogating the effect of consolidation durvalumab after chemoradiation. Even if you look at the curves, probably there is an effect numerical, but it's not statistically significant because we are losing a lot of patients progressing and during the first part. So for sure, a negative trial. But still, for giving you some more optimistic and positive message, we have the Keynote 799, which is a slightly different design as one cycles of chemoimmunotherapy priming. These were 2 parallel cohorts in squamous and non-squamous tumors. And given chemopembro for 1 cycle, then chemopembro radiation, and then consolidation pembrolizumab led to very good, I would say, progression-free survival in the cohort A and cohort B, with slightly better results for non-squamous patients presented at ASCO a couple of weeks ago by Martin Reck. And also overall survival is very promising. So this is for sure a good basis for new trials, and especially what I think is very interesting, and we discussed a lot in the previous talk, is the molecular response correlation with progression-free and overall survival, because in this trial at cycle 7, the DNA extraction was clearly in favor of patients with negative liquid biopsy. And this is very important for designing future trials. So we are quite optimistic for the 2 trials that follows Keynote 799, the KeyLink 12, it's randomized patient to this 1 priming cycles of chemopembro plus chemoradiation pembro, and then pembro olaparib or pembro alone or control arm Pacific, and also the co-formulation of anti-TIGIT vibostolimab and pembrolizumab in the KeyVibe 06 trial. We will see. We don't know anything yet about the results. So what was also being presented at ASCO is an update of the phase 2 trial COAST, which is another trial where you intensify the maintenance phase using IO doublets, especially using oleclumab and monalizumab. And the data confirms superior PFS for the experimental arms. And as you can see, here we are reaching 73%, 70%. It is very similar to Keynote 799. I would say provocatively that is very similar to the event-free survival of the neoadjuvant immunotherapy and surgical trial. Even if in more advanced patients, we cannot do something like that because, for sure, these two populations are completely different. We cannot compare them. But we're starting to see signals for PFS at 70%, that are quite good. Again, there are a lot of differences in comparison to other trials, but we are seeing something more because Pacific was 55% at 1 year. And we will see if they will be confirmed about the phase 3 trial. We have 2 phase 3 trials ongoing, one with oleclumab and monalizumab, and one with the anti-TIGIT and plus atezo, skyscraper 03. So and we will see if this consolidation approach will be more successful than simply anticipating the use of immunotherapy during chemoradiation. Then what about the news, the futures, what we do expect for the futures? Okay, these two situations are for us completely different, and it might be obvious, but we are treating this patient the same. It's 2 unresectable cases of stage 3 lung tumors, but in one case we have a very bulky right lung lesion, and in the second case we have a very small tumor, but with a couple of lymph nodes, one subcarinal lymph nodes. There is an heterogeneity in biology, we all know that, but it's also an heterogeneity in TNM, and Isabel Lopez explained very well how it is difficult to define resectability if you use only TNM, because obviously it is a problem. And the group in Einstein Montefiore in New York showed very well that the local control probability with radiation, with chemoradiation in these two situations is completely different. It's much more easier for us. It's obvious to control cases like the one you see on your right, patient without high-risk regions. Typical stage 3A, single station, I would say, or multiple node, but with a smaller tumor like T2, I would say T3, for sure not the T4 multiple and true bulky or N3 disease that we used to treat in the Pacific trial. So they started de-escalating the dose on the lymph nodes on the basis of the size of the tumor in a trial that is simply a phase 2 trial that pure radiotherapy related questions, but it's very important to us because if we understand that we can decrease the dose to the lymph node and the tumors on the basis of the size of the tumor, it is open the way for the adapting radiation therapy to response. And it is open also the way to, sorry, this is important, less lymphopenia, smaller volumes, less toxicity, higher completion rate of chemoradiation, and obviously a tentative of using induction therapy. In this first trial, again from Einstein Montefiore, using only pembro alone for patients with PD-L1 over 50% tumors, so highly selected, biomarker selected, and for patients responding, radiotherapy was given on the basis of the PET after response, so again with an approach where we consider the volumes after induction therapy, and we reduce the dose to the lymph nodes or in the tumor on the basis of the response. So if the tumors shrink, we use a different kind of dose. And as you can see on your curve on your right, very small numbers, but the 1 year PFS is 76% with only immunotherapy alone, chemo-free approach, and with a dose-adapted radiation. There is no more 60 gray, but it's 55 control versus 45, which means less cardiotoxicity, less lymphopenia. So this is a trial I am running in Italy with some other Italian colleagues, and our idea is to use 3 cycles of induction chemoimmunotherapy with chemodurva, plus a dose de-intensification in radiation therapy on the basis of response, 45 gray, followed by consolidation durva. My primary endpoint is safety. I still don't have any results to show to you, but hopefully it will be another way to think about these options. And already cited MTD Bridge is not really a trial looking at let's say induction therapy, but we will have a lot of data coming from the 2 points of multidisciplinary discussion, so it will be a very informative trial to know how multidisciplinary team, our surgeons see the patients first and judge them resectable, and then after neoadjuvant therapy, and what happens to patients that cannot receive surgery after induction. Then it is an open question, open issue. We don't know exactly what is their probability of chance of survival, and this will be a study that hopefully will give us some information on that, and we will also have a lot of translational endpoints. Also, using radiation therapy in stage 3, it can be also combined with surgery. This has been done in New York by Dr. Al-Torki and Dr. Formenti, simply treating the primary tumor and with 8 Gr per 3, so as kind of immunomodulating stereotactic radiation therapy without treating the lymph nodes. The idea was to increase the pathological complete response rate, and in effect, comparing to Durva alone, the addition of radiation therapy, obviously probably because we have more cytotoxicity, etc., was able to obtain 60% of complete response rate at surgery, at the time of surgery. And our colleague in Switzerland and the SAC group are running a very innovative trial in stage 3, integrating, I would say, 3 different dose levels of radiation therapy to the primary tumor alone without lymph node in a sequence, in a program that is based on neoadjuvant chemoimmunotherapy and then surgery, and I think, and then maintenance immunotherapies, and I think it will be very, very, very informative and very useful to have this data. It's a very nice approach. And then a second generation of study could also think about adapting the maintenance after chemoradiation to the molecular response. Dr. Modi and Dr. Dean at Stanford showed that we can obtain molecular clearance of the circulating tumor DNA even after chemoradiation, and it's related to prognosis. And they designed a trial on the basis of negativity or positivity of ctDNA after chemoradiation in stage 3. If you are negative, you receive durvalumab. If you are positive, you receive a combination of durvalumab plus the anti-CTLA-4 tremelimumab. And there is also, to conclude, a population which I mean, I studied a lot because probably in Italy we have a lot of these patients, especially that are elderly, unfit, that they cannot receive surgery, that cannot receive also chemoradiation, especially concurrent chemoradiation. But some of them cannot receive chemotherapy in any case because they have a lot of comorbidities and risk of complications. So we studied these populations, 8 years old median age, just to give you an idea of they are truly elderly patients, sorry. And in the DUART study, and the safety was very good. Hopefully, I will be presenting the molecular findings of the study, combining radiation therapy alone plus maintenance immunotherapy for 1 year at next ESMO. And also my colleague Andreas Riemer from Memorial Sloan Kettering, now in Fribourg, Germany, has conducted the DART trial, combining radiation and Durva plus Durva. And the results are quite good, and we will see the publication that are in preparation. There is also the Concord study platform, which is a very nice UK platform for patients unfit for chemoradiation, which is testing a lot of drugs, especially DNA damage response inhibitors, such as ATR inhibitors, ATM inhibitors, together with immunotherapy to look at what is the maximal dose of radiation therapy that we can give together with these drugs in the idea of reducing the dose and obtaining maximal effect. So my dream is that we will have in the future a stage 3, okay, unresectable, I would say non-oncogene deleted stage 3 non-small cell lung cancer, and we could offer many options, RT upfront or before or after induction chemo or immunotherapy alone, RT combination with chemo doublets or the damage response inhibitors. We can modify radiation dose and volumes. We can also look at the expected cardiac toxicity and look at the patient preference. Then we can decide together with the multidisciplinary team what is the best strategy, look at the response after our local program, looking at ctDNA, and then modulate our maintenance phase based on the molecular response. This is an idea for trying to adapting our treatment to baseline risk factors and also to response. Thanks so much for your attention. Thanks again, Jonathan, for the invitation.